Not sure if you can hear my baby screaming in the background, but okay. I am going to share my screen. So here's what I'm gonna do. Just to kind of get us a little bit caught up, I'm gonna fly through this and give you guys like the highlights, like the key points, key things that you really, 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 really need to know for this course as well as for future courses. So kind of starting with the heart in general. Let's actually see. Does this include? Okay, it does. Okay, sweet. Kind of going to fly at any point. If something's confusing, questions, interrupt me and let me know right away, okay?
Okay.
So first things first, anatomy of the heart. We really, 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 really need to have this down pat, knowing all of the different names of everything, as well as the way that blood is going to flow through the heart, okay? We always talk about starting with the vena cava. Superior and inferior vena cava are going to be dumping into the right atrium. The top section of the heart, where blood is entering and leaving, are the atria, and then the ventricles are the bottom portion of the heart. Okay, new blood comes into the atria, into the right atria, gets pushed into the right ventricle, then it's going to get pumped and pushed towards the lungs in order to get oxygenated. This is a fun fact, always, always, always a test question. The pulmonary arteries are the only arteries to carry deoxygenated blood. Always a test question. If not in this course, another course. Anatomy loves this kind of question. Pathology loves this kind of question. Like, you'll see this a good number of times, okay? So we go our vena cavas, right atrium to the right ventricles, to the pulmonary trunk, the pulmonary arteries. Then that comes back through the pulmonary veins into the left atria. From the left atria, into the left atria. From the left atria, it goes into the left ventricle, and then the ventricle pumps and pushes it up through the aorta, through the arch of the aorta, which goes to all of the rest of the body. You need to know, like the back of your hand, that pathway, okay? And I'm going to go into it a little bit deeper in this picture right here, okay? So we go from superior / inferior vena cava into the right atrium. Then we're going to go through the tricuspid valve, okay? This is also going to be known as the right AV valve. That's another AKA throws into there. From the tricuspid valve, or the AKA the right AV valve, it goes to the pulmonary arteries, arteries, there we go. Then goes to the lungs, comes back from the lungs, in through the pulmonary veins. Then it goes into the left atria. Atrium, yeah, atria is black. Then to the left atria, then it goes through the bicuspid valve, aka the left AV valve. There's another name for the bicuspid valve. It's the third AKA, I'm pretty sure.
Mitral.
Yeah, there it is. Yeah. Mitral. Why that one has 3 names? I don't know. It's fancy like that. People like to name stuff after themselves, so I give it more names. The left AV valve, and then that goes through. I missed something. From the tricuspid valve, it goes into the right ventricle. Sorry. Right ventricle, it goes through the pulmonary semilunar valve. There we go. To the pulmonary arteries, to the lungs, to the pulmonary veins, to the left atrium, through the bicuspid valve, into the left ventricle, and then through the aortic semilunar valve, and then into the aorta. Any burning questions about this whole order of things? Okay, cool. This whole process, understanding specifically like the order, the valve names, which ones are semilunar valves versus which ones are the cuspid valves, extremely important for later on, okay, for understanding all of the pathway. And when you start looking at EKG stuff as well and comparing EKG stuff to blood movement, it all kind of connects together. Okay, running through cardiac muscle real quick. Again, they're striata, they have sarcomeres, they have tons of mitochondria because we have to have as much energy as humanly possible for the heart. We have the intercalated discs. The intercalated discs are essentially like little holes. They connect the different muscle cells together, and they have little gaps, little gap junctions in between them to allow for the flow, the transfer of ions in order to pass action potentials all the way through the cells so that you get the heart acting. You have the signal traveling all the way through the heart muscle tissue so that the whole heart gets the signal. Okay? Any burning questions about heart muscle cell kind of makeup? Okay. Continuing on. Only real other questions that come from that, the questions that you'll get in the test are typically like makeup of the cell that has sarcomere, that has that kind of those characteristics, that there's a gap junction. What the function of the gap junction is to let the ions and the signal pass through. Then there are these things called desmosomes. Desmosomes are essentially the proteins that glue the two cells together and hold them in place. Obviously, as the heart's going to be under a lot of strain, a lot of pressure, as there's a lot of force and muscle like going through it. So those are the questions essentially you're going to get asked a lot about the cardiac cells themselves. And we'll talk about a little bit more further down. This I'm going to mention here. This is more anatomy kind of stuff, but it comes into play a little bit later on. We have this thing called the cardiac skeleton. The cardiac skeleton is this elastic tissue. It holds kind of the valves in place where they're supposed to be, and it also separates our atrium, the atria, from the ventricles. Okay? We'll learn why that's super important. You guys have already talked a little bit about EKGs and that kind of stuff, and like what the P wave versus the QRS complex are. And so we'll look why the cardiac skeleton is super, super important in maintaining and keeping a good like EKG waveform. Okay, plays a very, very important role in that. Again, the heart has the actin and myosin filaments. It's very, very similar to skeletal muscle as far as like, the tropomyosin, the myosin, all of those kind of filaments, calcium binding to troponin, all of that is very, very similar. The cross bridge cycling, the power stroke, all of that stuff is essentially identical. Big difference is going to be what is going to be kind of the actual action potential itself, how it's generated, how it started, and then some of the ions that perform in it. Okay, so cardiac muscle cells, 99% of the cardiac cells are contractile, and then we have autorhythmic cells. This is another question, big test question. If you ever see this word autorhythmic, put a pretty star by it, because that is always what they ask about with the heart. they'll ask which of the following applies only to cardiac cells, and they are autorhythmic cells. Technically, some of like the small intestine and like large intestine kind of stuff have a little bit of autorhythmicity, but we kind of ignore that and we focus on cardiac cells. So if cardiac is ever not an option and it's talking about autorhythmic cells, second best answer choice is like intestine, smooth muscle type stuff. Other big thing to note about the cardiac muscle cells is we're going to be dealing, rather than sodium, with skeletal muscle. Remember how in our, oh, I almost just drew our, so in our whole graph here, when we reach threshold in a skeletal muscle cell, we deal with sodium channels. The difference with cardiac versus skeletal muscle is that with cardiac, we're going to be dealing with calcium channels. Calcium channels are our main channels. Okay. A little bit more anatomy type stuff that will come back to all of this as well. Two main nodes, they're locations where that autorhythmicity takes place. We have a bunch of cells, those autorhythmic cells that meet up and where they kind of hang out to help set the pace of the heart. Big one being the SA node, the sinoatrial node, SA node. You'll see, and when you talk about EKGs, sometimes you'll see sinus rhythm. Autocorrect, I love it. When I write sinus rhythm, does anybody have any idea kind of what that means, what that refers to?
It's like the normal rhythm of the heart that's regulated by the SA node.
Exactly, perfect. This is between 60 and 100 beats per minute. Anything within this range, 60 beats per minute or 100 beats per minute, 61, 62, 63, 70, 84, 85, 92, anything within that range is considered normal SA rhythm, okay? As soon as we go above or below, that's when we call it something different. If we go below, it's called bradycardia. If we go above, it's called tachycardia. Okay? Brady means slow. Just like a biochemistry, we want to learn the prefixes. Brady means slow. Tachy means fast. So cardia, referring to the heart. Eventually, later on, we'll also talk about apnea. I think it's apnea, like that. Bradyapnea and tachyapnea. Let me see the spelling on that. I think it's just apnea. Tachyapnea, bradyapnea. This suffix, the PNEA, is going to mean lungs and breathing. So like tachypnea, breathing too fast, bradyapnea, breathing too slow. So not important for heart stuff, but we circle back eventually in the next unit with lungs. So just understand those words under Brady versus tachy. That's also typically a test question. Usually it's in the form of they'll give you an EKG, and with an EKG they want you to identify, is the patient bradycardic, tachycardic, or normal? Have you guys talked about how solving that, how to figure out if it's Brady, if it's normal, too slow, or too fast?
This week's lecture videos that he posted, he talked a little bit about it.
Okay. I'll just pull it up super quick. I'm going to kind of intermingle this stuff so you can look at it in the future, you know, kind of bouncing back and forth. So when we get to EKG stuff, you can see it. So EKG. So with the EKG, you have all these little tiny boxes, right? Open, 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 boom. Here. You have all these little boxes. Each of these little boxes refers to, it actually is a unit of time. Okay, they mean a couple of different things. They mean time. They also mean like the amount of millivolts and all that kind of stuff all the way through them. So literally what we do, and if you look at it, you can kind of see how you have a bunch of these small little boxes, and there are slightly thicker lines that make big boxes. Can everybody see that? Yes, no, maybe?
Yeah. Yes.
Yeah.
We have like, draw, dude. Little box, little box, little box, little box, little box, big box. There's 5 boxes. Each box represents 0.2. Let me double check, make sure I say the right thing. Each small box is 0.04 seconds. So 4, 8, 12, 16, 20. So 0.2 seconds per big box. And so we kind of look it up and add it up. So like normal sinus rhythm, if you think 60 divided by, you know, a minute, 60 equals 1 second per, and then 100 divided by 60 gives us boom, boom, 10/6, which is 1.8-ish, I think, something like that. So we look at 1.8 seconds, so 0.2, 1 goes into 0.2, or 0.2 goes into 1 5 times. So if we're somewhere between 5 big boxes, like it's like 5 and 7, I think, big boxes, it's typically considered like super normal heart rhythm.
So is that when you're counting those and you're looking through that, is that like P wave to T wave, or is that just QRS complex?
It's QRS complex to QRS complex.
Okay.
Yeah. So this is 60 beats per minute. This is actually it's 5 plus 4. Actually should be 9. 5 to 9 is 100. So between 5 to 9 big boxes. So 1, 2, 3, and then a little less. There's 1, 2, 3, 4-ish. So 1, 2, 3, so 4 big boxes. So technically this is closer together. I mathed wrong. 1 sec, guys. 60 beats per minute, 100 beats per minute, 1.8. I mathed a little bit wrong. It should be less than this because 100 should be less than. So 5 is the most it can be, and then 100. Sorry, it's been a long day. It should be, let's see, big boxes per. There we go, it's 3. Glad I caught that. QRS complex is connected 3 large boxes apart, therefore the ventricular heartbeat is 100 beats per minute. And if I actually did the math correctly, we would see that So 3 to 5 big boxes. So here, 1, 2, 3, between 3 and 5. So this is normal rhythm. Sorry, Elizabeth, what was your exact question again?
So when you're counting that to see if it's within normal, you said it's QRS to QRS?
Yeah, we do QRS complex to QRS complex.
Okay.
The peak. This is technically a little Q, R, so R wave, R wave, R wave to R wave is what we do, what we measure.
Okay.
Mostly because that's the easiest to measure, wherever the spikes are.
Okay.
Okay. Like I said, we'll come back to that. So that's all with the SA node. We also have the AV node. So SA node is in the upper corner of the right atria. The AV node is going to be between the two atria, heading down into the center of the ventricles. This is why this is important, that cardiac skeleton that I mentioned earlier. The cardiac skeleton sits right here and prevents random waves coming from the SA node, coming all the way across, from going directly into the ventricle. Whereas, so they all have to funnel to the AV node. So it travels from the SA node and it all funnels to the AV node. And then the AV node continues the signal to the AV bundle, aka the bundle of His. And then it goes down bundle branches and eventually Purkinje fibers. We'll get more into that electrical conduction system, because this conduction system is another thing that's one of the things that you need to have just down pat memorized, step by step by step, kind of where everything goes. So writing it out, and actually let me real quick do this right here. I'm gonna go ahead and throw this. Hopefully you guys can download that and see that, throw that into the chat window. And then we'll do our electrical. Okay. So we start in the SA node. From the SA node, we branch out into the atria. From what I understand, Dr. Tate does not test on this, but every other teacher before him has. So in case he does, there's a specific bundle that goes from the SA node in the right atria over to the left atria to make sure that the signal gets passed at the same time. And that's called the bundle of Kent. What was that?
I thought it was bundle of His, my bad.
No, different bundle. They call it bundle of Kent. There's a bundle of Kent that goes to, might not even be bundle, let me see. I'm pretty sure it's the bundle of Kent. Yeah. There's a bundle that goes off into the left atria called the bundle of Kent. That it wasn't tested on last trimester from what I heard. But if he does decide to throw it in there, just so you guys have it. Okay, it's gonna go to the AV node. Super important here. We get a delay, we get a gap, a pause, which is why in our EKG, I'm going to show you guys on the EKG, right? We have our P wave, and then we have this little segment right here. What's this? Do you remember what this segment's called? You've watched this video already this week. Called a PR
yeah.
segment. Trick of remembering segments versus intervals. Segments do not include either of the waves that they're referencing. Intervals include the wave that's behind. So from the beginning of the P wave to beginning of R wave is the P PR interval. So segment does not include either of the waves. The interval includes the wave in the back. Okay. So right now we're talking about, at this point, talking about the electrical signal coming in from the SA node to the AV node. That is our P wave. Right there. The depolarization, P wave, equals depolarization of the atria. Okay, then our PR segment is here. It's at the isoelectric point. Isoelectric point is like the neutral point for all of our electrical activity. This PR segment is the signal is at the AV node, and there is a pause at this location. Okay, have you guys talked about that at all?
It sounds vaguely familiar.
Okay, I'm gonna keep jumping back and forth in this. I know it's kind of like mixing and jumbling it all together, but it really does make a lot more sense if you can put all the pieces together in the long run. Okay, so we have the AV. So we get to the AV node, and there's a pause. It pauses for 0.09 seconds. Double check Dr. Tate's material, because sometimes, depending on which diagram he uses, sometimes there are ranges of like, oh, it can pause between this amount and this amount. But it just depends on which reference he's using. After that pause at the AV node, it continues into what's called the AV bundle. So the AV bundle is also known as the bundle of His. And there is another pause, pauses the signal for 0.04 seconds. So roughly, give or take, our PR segment should be the here's this the segment part. When we get there, we get there. There's specific times of how how long they are in the specific EKG, but we'll get to those when we actually look at the actual EKG stuff. Okay, this pause here at the AV node and the AV bundle, why do we think it's important that we get a pause there, that the signal doesn't immediately go down into the ventricles?
So the valves have time to react.
Exactly. So the valves have time to react. And also, if you think about it, we're looking at electrical signals here, not muscle contraction. We hope that after the electrical signal goes through, that we get an electrical contraction, but we don't know for sure, just because we see an electrical impulse, that we're getting a contraction. Okay? So they're two separate areas, two separate things that we need to look at. Okay? So we need a pause at this AV node AV bundle from the atria to the ventricles to allow for the atria to contract, to squeeze, and have those valves open and actually push and empty the blood from the atria into the ventricles. Okay? Does that make sense? Why there needs to be that pause?
Yes.
Okay. After that pause, it's going to go down the bundle branches, which is located in the ventricular septum. Ventricular septum right here is the portion in between. It separates the left and the right ventricles. And then after the bundle branches, it goes into the Purkinje fibers, which are located furthest away along the walls of the ventricles. Okay. This is another process that we need to know super well. One, because it's tested on a lot, and two, because this process is what is going to tell us and help us understand the EKG. And then when we look at something at the EKG and says that thing looks funky, we can walk it back to what's happening with the electrical signal in the heart to give us like the actual diagnosis of, okay, what part of the heart is actually having issues based on this EKG. And then it opens up our window of diagnoses, what does stuff look like. Okay, so we need to have this down pat, really understand that. Okay. Here's another pretty picture kind of that pathway. I'll go ahead and paste this in the chat as well, just so you have it right here. There's more. And again, these are based off of Dr. Van Winkle's notes, which are her slides, which are really good. And a lot of it like repeats a lot. So, okie dokie. Did Dr. Tate spend a lot of time kind of on like the actual channels and stuff and like the action potential of the whatchamacallit, of the heart? Like the channels and stuff that are opening?
Not that I remember, but that doesn't mean he didn't.
Okay. Biggest things to remember. I'll go ahead and throw this picture in. Biggest things to remember are that it's not like skeletal muscle where you get like the hyperpolarization and all that kind of stuff. It's really consistent and very contained. Okay. So we have, remember way back when I talked about leaky channels and funny channels way back in the very beginning, like week 1?
Yes.
Leaky channels, funny channels, they come into play here in the heart. You have these the slow channels, these leaky sodium channels that give the heart the autorhythmic capabilities. Without these funny channels, the heart wouldn't be autorhythmic. So it's thanks to these guys that it has that property. So what happens is these channels slowly let sodium through until it hits threshold. And whereas in skeletal muscle, we get voltage-gated sodium channels, instead within the heart, we get voltage-gated calcium channels that open up. The voltage-gated calcium channels open, calcium rushes in, we get our spike, our depolarization, and then the voltage-gated sodium channels open and it drops back down. It doesn't hyperpolarize, it drops back down to its resting spot. Those voltage-gated potassium channels close, and immediately it starts going again with our sodium leaky channels. Okay. Any questions about this? Okay, moving on. General pathways, AV node. We talked about the AV node. Why the delay? For the emptying of the atria. This will be super important whenever we get to heart sounds, like what kind of stuff is going on with that. bundle of his and the bundle branches. They have the left and right bundles. Okay. The Purkinje system. This is usually how this is worded. The sinus node is the cardiac pacemaker. This is normal rate of discharge. Normally heart rates is somewhere. This is like the quote unquote typical, like the actual real world typical. Somewhere between 70 and 80 is like the real world typical. But again, 60 to 100 is considered normal. So in a test question, this is always the answer you want to pick, that 60 to 100. That's our test question answer. And then the sinus node is the cardiac pacemaker. When we talk more EKG stuff, there are times where the SA node can fail, either because of like damage to it or because there's a weird signal going on or a handful of different things. And in that case, the AV node actually takes over. Okay. So there's autorhythmic potential in the SA node, in the AV node, in the Purkinje fibers. So like the body has backups on backups on backups to make sure that we stay alive as much as possible. Because being alive is typically the happiest way your body is. Okay. We'll talk more about that when we get into EKG stuff. Here's the other part that we really, really, really want to remember. So here, just like we had our action potential graph for the muscle cells, and then like the actual contractile, so like the action potential and then the contraction type of things, we actually have the autorhythmic cells action potential. So the action potential that goes through the autorhythmic cells. Remember, the autorhythmic cells make up 1% of all of the cells of the heart, and then contractile cells are the 99%. So the autorhythmic cells are still connected through those gap junctions, right? Does anybody remember the name of the protein that holds these two things together?
Desmosomes.
Yeah, or desmosomes. What's this whole structure actually called? The whole thing? Does anybody remember? The intercalated disc. Does that ring a bell?
Yes.
Yeah.
Intercalated disc. Okay. So just like we have the autorhythmic cells action potential, where we have the leaky channels coming up, voltage-gated calcium channels opening, potassium depolarizing. We also have the contractile cells doing their thing. Here's a beautiful little step-by-step. So we get depolarization. So thanks to the autorhythmic cells, they depolarize, and then they're going to leak into our cardiac cells. Fast sodium channels open at threshold. The cardiac cell is stimulated and depolarizes. The membrane potential becomes more positive. The voltage-gated sodium channels open and let sodium rapidly flow into the cell. The membrane potential reaches about 20 before sodium channels close. So this first part, our initial depolarization in the contractile cells, is thanks to sodium. So different from the autorhythmic cells. Autorhythmic is thanks to calcium. The depolarization of the contractile cells is thanks to sodium. draw both of those. I draw each of these right next to each other, just like this. And just like I told you guys to do with the action potentials and stuff of the neuron, of the nerve cell, the skeletal muscle cell, I draw these out as well. And the specific steps of what opens, what closes, when and where and why. Okay, so up here at the peak, those fast sodium channels close. And the cell begins to repolarize because once it's up here, those voltage-gated potassium channels are going to start opening. Then we get this plateau because we get calcium channels that open. So while potassium is leaking out, calcium starts to come back in to give us a nice plateau, and that gives us a little bit of a pause. If it says this reason for the pause here, the reason for that pause, that plateau, one is to prevent like accidental repolarization, extend the absolute refractory period, and also to allow for the whole heart muscle, the whole heart to contract. So because if you remember the flow of electricity, right, it takes time to get from the AV node, bundle of His, and then go through all of these, the bundle branches, and get all the way to the Purkinje fibers. It takes time to travel from here all the way up to here. So if these muscle cells that are along this path start contracting first, if these ones were to finish contracting before the cells way over here were able to contract, we wouldn't get as nice of a contraction, an all the way around contraction to squeeze and push blood out. So we get that delay, so that way we get a continual contraction until the entire heart contracts, let's just say the entire ventricle or the entire atria contracts and pushes the blood where it needs to go before it relaxes, and then it can have another stimulation.
So with that, this may be
Go ahead.
thinking a little too far ahead, but if that is like not functioning properly, if we don't get that like plateau phase, is that where you get like AFib and VFib from?
You can get AFib and VFib from it's typically not due to the contractile portion of stuff. It's more to do with the action potential side of things. A lot of times with AFib and VFib, you get like a messed up signal being sent. You get a repeated signal sent outside of the SA node or the AV node. Okay. So a signal is getting generated too often from another place.
Okay.
And we'll take a look at that when we get there. Good question, though. Okay, so we got the plateau thanks to the calcium channels. Then the calcium channels close again after the plateau, and those potassium channels, more potassium channels open, and we get depolarization, and we get back down to resting membrane potential. Again, just another example of the same thing. More pretty pictures of all of our stuff. Good comparisons, skeletal, cardiac, smooth muscle, how they all compare. Again, this is the contractile stuff. Very, very similar to kind of skeletally muscle type stuff. Did Dr. Tate, go into it all? Did he go into like the calcium spark? Does that ring a bell?
Not for me.
Okay, I'll explain it briefly just in case. So very similar to obviously the skeletal muscle, we have our T-tubule, right? Our signal gets transferred along either from, from the gap junction or through like the T-tubule, depending on where the signal exactly is coming from, whether it's from, directly from the contractile cells or coming from another one of the other muscle cells. So either way, with this signal coming in, we have calcium channels that open along the surface. Yeah, down here, this is where it talks about the calcium spark. So the calciums, we have calcium coming from, we have things coming from two different places. We have calcium ion, like calcium channels coming on from the membrane, the plasma membrane of the cell, as well as through the gap junction. So we get calcium that comes in, and that initial influx of calcium that comes in and shows up everywhere ignites. We call it a calcium spark. What it does is the sarcoplasmic reticulum inside of the cardiac cell notices that there's an increase in calcium, and it causes it. That's the calcium that's coming in from the other sources sparks the sarcoplasmic reticulum to just release a bunch more calcium. That's really what the big difference is. We call it the calcium spark, and then everything else after that is the same as skeletal muscle. Sorry, it took me a second to get all the way through that and wrap my own brain around it again. Does that make enough sense? Is that okay?
Good here.
Okay. There's more again. Same thing as with skeletal muscle. We have those DHP receptors, the ryanodine receptors, all those kind of guys. I don't think Dr. Tate doesn't usually get into this stuff. Just there are technically different like types of ryanodine receptors in skeletal muscle versus cardiac muscle. Dr. Tate doesn't really get into that. There we go. Okay. Cardiac cycle. This will help us a lot as well with EKG kind of stuff. We have systole and diastole. This is always a test question as well, just like the straight definitions of systole and diastole. Okay. So system, I'm going to type this in the chat. Systole equals ventricular contraction. Okay. Very, very specific. Ventricular contraction. I do not care what is happening in any other part of the entire heart. I care about the ventricles only. Okay. So when the ventricles are contracting, is stimulated by an action potential, when they are contracting, ventricular contraction, that is systole. Okay. Diastole, ventricular relaxation. As simple as that. Do not confuse those, and because he will, the way that he'll word a whole bunch of questions, is which of the following is not occurring during ventricular systole, or which of the following, or which is during systole, or which of the following is not occurring in diastole, or which is occurring in systole, or is occurring in diastole. And there'll be tons of like little one word changes in the answer that change your answer. Like it'll give you stuff like, oh, like the atria are contracting, the atria are relaxing. Like, and if it's talking about the atria stuff, ignore the atria, focus on the ventricles. We know that the ventricles are contracting during systole. the ventricles are relaxing during diastole. Okay. This is a little bit of EKG intro type stuff. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization. And because the QRS complex is so big, it hides atrial repolarization. And then our T wave is the ventricular repolarization. We'll keep seeing that when we talk deeper into EKGs. I don't know if he mentions Frank-Starling, but Frank-Starling mechanism is essentially just saying that each tissue of the body controls its own local blood flow, like how much blood it needs. So like if the heart needs more blood, it's going to dilate those specific vessels and help itself get more blood. If certain organs need more blood for whatever reason, whatever is going on depending on the body, they're going to control their own local blood flow. And then all local blood flow returns to the heart through the veins. Yeah, I don't remember. I don't think he talks about that, but in case it does come up.
It did in our lab, I think, last week.
Did it? Okay. More kind of review stuff. Cardiac cycle. Okay. Have you guys seen this chart or this graph or either of these guys?
That second one for sure.
Yes.
Okay. This second one, live, breathe, and die by this chart for the next year of your life. Okay? You are going to have so much stuff that comes back to this chart. This is another one. Please, for the love of everything, you need to be able to draw this in your sleep. Okay? Did I make that clear enough for you?
Yes.
Okay. You will have nightmares about this chart. Trust me, I did. The biggest thing that we need to know within this chart, and then we're going to add some more stuff to this as well. Actually, I can just do this. New slide. Nice. So we have our chart right here. Okay. We split it. This is systole. This is diastole. What's systole again?
Ventricular contraction.
Good. So we look at this chart. Down here at the very bottom, we have a period of filling. Filling from where? What flows into what within the heart? So blood is going from the atria into where?
The ventricle.
The ventricles.
Into the ventricles. Okay. It's going to do this in two different ways. Okay. 75% of our ventricular filling, this whole chunk, is passive. So we call it passive filling. If this is passive filling, what do you imagine the last chunk is?
Active.
Active.
Active filling. So majority of the filling of the heart. So blood, at the very, very beginning, blood is in the atria. let's start on the right side of the heart, right? So from the right side of the heart, from the atria, what is the name of the valve that opens to allow blood to go into the right ventricle?
Tricuspid.
Good, the tricuspid. Little trick to remember, the right side always has 3, okay? The right lung has 3 lobes. The right AV valve has 3 cusps, okay? The right side has 3. The tricuspid, we'll actually go say right and left. So the tricuspid, and what's the name of the one on the left?
Bicuspid, mitral, left AV.
Good. The tricuspid and mitral valves open. And we're going to label that 1. So 1, this spot right here is 1. The tricuspid and mitral valves open, and we get passive filling. Passive filling happens thanks to gravity. And then we get active filling for the last little part. Happens with atrial contraction. Oops. There we go. So blood fills, blood is in the atria, they open. Now the ventricles are full of blood. As soon as the ventricles are full of blood, so right here at point 2, the ventricles are now full. So what needs to happen? When the ventricles are full, the AV valves close. I want you to think of the valves as doors, right? Does a door make noise when you open it or when you close it?
Close.
When you close it or when you slam a door, it's hard to slam a door open, right? You just open it really fast, it doesn't make noise. When you slam the door shut, it makes noise. This is where we get our first heart sound, okay? This is our S1 heart sound. Have you guys talked about heart sounds yet?
Yes. Yeah. Lub dub.
Yeah,
Yes,
well, lub dub. That lub, that first part, is our S1 heart sound. Is the slamming shut of the AV valves because the ventricles are full and they're going to start squeezing. So at the same time the AV valves close, the ventricles begin isovolumetric contraction. Let's break down that word. What does iso mean?
Same.
The same. Volumetric. Volume. What does volume mean?
How much of something? I don't know.
Good. Yeah, it's how much of stuff. So in this case, we're talking about milliliters, right? Milliliters of blood. So literally what isovolumetric contraction is the ventricle is contracting. So pressure is building, but there is the same amount of blood the whole time. So the amount of blood in the ventricle is not changing at all because there's nowhere for it to go. So isovolumetric contraction of the ventricles. Eventually, we reach a point up here towards the top. Everybody here has heard of blood pressure, correct?
Yes, sir.
Yes.
The two numbers of blood pressure, there's a top number and a bottom number. Does anybody know what we call the top number and the bottom number?
Systolic.
Systolic and diastolic.
Systolic over diastolic. Hey, we talked about those words before, right?
Yep.
So systolic
Mhm.
blood pressure, if we look at blood pressure, we literally look at the pressure in the blood vessels when the ventricles are contracting. And that's going to be over the pressure in the blood vessels when the ventricles are relaxing. This is our blood pressure. The pressure in the blood when the ventricles are contracting, the pressure in the blood when the ventricles are relaxing. So like our systolic blood pressure, does anybody know what's quote unquote now is considered normal blood pressure?
120/80.
Yeah, depending on what Dr. Tate uses, about 5, 6, 7 years ago, something like that, a new chart came out. The technical, like new normal is less than 120 over less than 80 is considered
Yeah,
normal. 120 over
Ask any
80 is like,
functional neurologist, though.
yeah, yeah. So technically, look at what Dr. Tate gives you guys and go with what he gives you. But this is most often we learn the 120 over 80. Okay. But technically now it's less than 120 and less than 80 is considered normal, healthy. But
That's
whatever.
crap.
So 120. Let's just say right now this person is nice. They're 120 over 80. That's our systolic blood pressure. So what that means, if we're pushing a door, right? Let's say if we have somebody who's 120 pounds leaning against the door. So we have 120 pounds of pressure being pushing a door and keeping it closed. How much force do we have to exert to open that door?
At least 120.
Yeah, we have to go over 120. So we hit 120, then we're balanced. As soon as we step over that, the door starts to open. So that's our isovolumetric contraction. Our ventricle squeezes, it squeezes, and the pressure builds, pressure builds, pressure builds, pressure builds until it hits literally right here. This point right here is our systolic blood pressure, is right there. As soon as we hit that systolic blood pressure level, a valve is going to snap open. The semilunar valves open right there. What are our two semilunar valves? What are those called?
Aortic semilunar valve and the pulmonary semilunar valve.
Good. So when the pressure in the ventricle reaches systolic blood pressure, the semilunar valves open and blood, I'm just gonna say the semilunar valves open. 5, we have ejection. This is when blood goes from the ventricle into the arteries, specifically the pulmonary arteries or pulmonary/aorta. Boom. This is 4 right there, and this is 5. Now all of the blood leaves the body, or leaves the ventricle. It gets squeezed out, gets pushed through. Once all the blood is squished through, we get to this point right here. What's going to happen? we have all the pressure. All of the pressure gets pushed through, and all of a sudden the pressure is less. But we
Valve's gonna
still have that
close.
same 120. Yeah, the valve closes. So right there at 6, semilunar valves snap shut. And remember, whenever a valve shuts or closes, whenever a door closes, what do we get?
Sound.
S2.
We get a sound, right? So we get our S2 heart sound. Very nice. Is all of this making sense?
100%.
Yes.
Whole lot
Sick.
more than it did before.
Good. And that's what I
got a
want
question,
each of you. Yeah, go for it.
These notes, should they get uploaded up onto the Google Drive?
On the my Google Drive, yeah.
Yeah.
Yeah,
Like-
these
does it
all
get
should be.
updated?
As I do it now, just because I haven't tutored Phys in a while, if you want these specific slides that I'm filling out, I can copy paste them. I'll keep copy pasting them into the chat window. Also, I forgot to send it. If you guys aren't part of the actual Teams tutoring, let me find the. So the Teams channel, the tutoring services drop-in tutoring, this channel, anybody can join. So you guys can join this channel and you guys can actually come back and see like all of the recordings and everything. Recordings and chats and everything stay in here available for you guys
That's
to
perfect.
be able to see. So
Okay, cool. Because I was just about to say I don't see the chat, but it's because I need to get on there. Okay.
yeah,
you,
if
Drake.
you open up yeah, and if at the end of it, if you guys want me to as well, I can just download each of these things that I uploaded into the chat and these things that I added, and I can either send them to you guys or throw them into the group me or whatever is easiest.
Yeah, if you want to throw them into our small group team,
Yeah,
that would
I
be
could
awesome.
throw
And
them
then
there.
Peyton, I can send them to you from there.
Thank you.
Sounds good. Okay.
Works.
So our S2 heart sound. So our S1, a lot of teachers are leaning away from the lub dub, but if you want to technically compare, there's S1 is our lub, and then others are dubs. We get lub dub, lub dub, lub dub, lub dub. AV valves close, semilunar valves close. AV valves close, semilunar valves close. Like that. And so if we think like we slow this down, physiology, we slow things down a lot and we look at like the nitty-gritty details. But in reality, think about this whole process that we've talked about. We haven't even finished this process. This entire process is occurring 60 to 100 times a minute. So every single second of your entire life, this entire process is occurring over and over and over and over and over and over until you die. Just crazy. Babies who have heart rates of 120 to 140, imagine this happening over and over and over that quickly. So cool. Okay, continuing. Next part, after we've contracted, we've shot out all the blood. Now our valves close. Finally, we get iso volumetric relaxation. Breaking down this word, what does this mean? Iso means what?
Time.
Volume means
Stuff.
all this stuff. Relaxation.
No
Self-explanatory,
contraction. Yep.
Isovolumetric relaxation, again, of the ventricles. So the ventricles relax and volume stays the same, pressure goes down. So the reason why this little chart is so important, I should clarify, then we start over again from the very beginning. And I'll add one more note in here after I say what I'm going to say right now. The reason this chart is so important is because this is what's going to define for us a ton of our pathologies. So when we hear certain sounds, certain things that are not normal, we can tell when those things are happening, in what stage they're happening, and then from there determine where the problem is. For example, if we're listening to a heart and we hear the lub, and then before the dub, we hear like a gurgle sound, like a, so it's lub, lub, blub, lub, dub, lub, dub. We know somewhere between the lub and the dub, we're having an issue. And because blood, typically the issue is going to be, the issue is going to be happening. I shouldn't say typically. Sometimes the issue is the blood is not going through the valve properly, either because the valve shape of the valve or something's wrong with the valve, or the blood is backflowing through the backwards valve because the valve isn't closing properly. So, for example, you'll learn all of the specific sounds and stuff, but like, let's say after our lub, we then hear a higher pitched whooshing sound, like a kind of sound. So it's lub, dub, lub, dub. Kind of sounds like that. When a valve, the semilunar valves, mostly the aortic semilunar valve, is stenotic. There's a word for you guys to know, super important. Stenotic or stenosis. Maybe you've heard of like lumbar stenosis or anything like that. What is, have you guys heard that word before? Stenotic or stenosis?
Yeah, it's where it's getting thinner, like more contracted.
Yeah, it's not opening all the way like it should. So there's less space for blood to go through. So it takes longer, it takes more pressure for that blood to get all the way pushed through. Whereas that's a problem. So a valve can be stenotic. And then what we want them to be patent. That means open. If you learn those two words, Dr. Moore in Try 4, or Blended gets to campus in Try 4, right?
I think so.
Right before try 5.
Right before Try 5? Yeah, if you learn the word stenotic and patent and you know those words for Try 4, Dr. Moore will love you. Okay. But these kind of stenosis, or you'll have another issue you'll typically run into is regurgitation. Regurgitation, where blood is backflowing after it goes through. It's like it'll go through the aortic semilunar valve and then it flows backwards into the heart. You can hear those things, and then you can also start to see kind of those issues on EKG because it causes changes to the heart. So that's why this whole chart, you're going to see a lot of this. There's going to be a handful of questions on the test, on the lecture exam, on the lab exam. There's going to be a handful of questions. You'll see this in Gen Path, a little bit in Phys 2. Systems pathology, you'll see this, and you'll also see this in physical diagnosis. This does not go away. This whole process, all this stuff, this does not go away. It'll come back over and over and over again. So make sure that you guys see this. Along those same lines, talking about pathology, there are two more sounds that can be heard that are also usually considered pathological. There is an S3 sound and an S4 sound. These, you'll probably never actually hear the S3. You might hear, I've heard an S3 in a patient before. S4 you probably won't ever hear just because it's super, super subtle, and we're not listening to hearts all day, every single day. But what's happening with the filling, sometimes the heart, in two cases. One, either the heart is still developing. If the heart is still developing, like in children, a lot of times you can hear an S3, and that's completely normal. But as you get older, your heart isn't as compliant, meaning that it doesn't have like the same kind of squish, the same give that it should have. And so when you passively fill and you actively fill, the blood is falling from the atria to the ventricle, and you can have an S3 and an S4, and that's just the blood from the atria hitting a non-compliant ventricle. It's like the ventricle is a little firmer. It's like dropping a water balloon onto pavement. You kind of hear a splat. That's what those sounds are for. Typically, you'll get one or two questions thrown in there about S3 and S4. S3, normal in children, pathological in adults. S4, always pathological. I'm not sure if that will be like included in Dr. Tate's stuff.
We had a lab
blends together a
manual
little bit.
question about it.
Well, there we go. It's like I know this stuff. It's crazy. Systole, this is just a bunch of review stuff. Here's another chart just showing systole, all of our specific things, where things open, where things close. And then we'll talk the Wigger diagram, this kind of thing. Let's see. This is again just review, going through all this kind of stuff. This guy right here, which we saw this portion before. This graph here, this is where you start to you learn this graph really, really well. This graph is the same thing as this graph, just spread out a little bit differently. So we can see it's saying the exact same thing, where we have our pressure, rather than showing pressure over volume, this just shows the pressure. This down here shows the volume. So it's taking this other chart, this chart, and making it more complicated for absolutely no reason. It just separates out the pressures with the volume, and then matches it up to the portions of the EKG and where the sounds are. So spend a little bit of time with the Wigger diagram to kind of go over it and kind of see how it's labeled in these different spots. Mitral valve closes here, so you get the isovolumetric contraction is occurring. So because we know with isovolumetric contraction, pressure goes up. And when we get to the top, the max pressure that we have is where ejection happens. And then our pressure starts to go down. We get the isovolumetric relaxation. Pressure goes down. And then during this time, we have our passive filling. And then our little increase in pressure is due to active filling. And then again, the same thing happens. We start to get isovolumetric contraction. The mitral and the tricuspid valves close. And so we start to build pressure again. So it's the exact same graph, just for some reason they wanted to put it like this. And personally, I think it makes it more complicated, but we need to be able to read it so that way we can understand how to read it, essentially, and kind of where things line and match up. Does that help with the Wigger diagram?
For sure.
Here's another picture of it. Don't worry too much about it. Understand the other chart, and just I wouldn't draw this one out. I would look at the other chart. Understand this guy. Understand the EKG separate, and if you understand each component of it, of what's happening where, you can link them up based on knowing the processes that are occurring. Again, repeating systole, diastole. This is all just. He might ask you a question about preload versus afterload. Preload is the volume of blood that's in the ventricles at the end of diastole, also known as the end diastolic pressure, versus afterload is the resistance the left ventricle must overcome to circulate the blood. So kind of comparing, the pressure in the aorta, so like our systolic blood pressure, plus if we have other issues, like this little key shown right here is stenosis, that kind of stuff. Okay. And we went through a lot of heart stuff. We'll talk more about like cardiac output and that kind of stuff a little bit later. How's everybody doing?
Feel
Pretty
better
good on
about it
that
than I
stuff.
did.
Better than
That
I
was a
did.
lot of information. So just to recap, I want to make sure the things that I want you guys really to know. The way that blood goes through the heart, the path that the electrical signal takes through the heart. Here's that same thing as well. The rhythm, or the chart specifically for the autorhythmic cells, the action potential of the autorhythmic cells. I didn't include it here as well. I want you to also know the chart that is the action potential through the cardiac contractile cells. And then this beautiful diagram, know that super well. And then getting comfortable with comparing it to the Wiggers diagram. That's recap. Those are the big things. Most of your exam questions, I won't say most, but a good chunk of your exam questions are going to stem from and come from those specific chunks of material. Where if you get those down really well, those will feed into a lot of the questions that you're going to have. Any burning questions up to this point?
Yeah, really. You explain it way better than he does.
Absolutely 100% agree.
I've done this a couple of times, so I also feel like when you take the class, you are really forced to truly learn the material like much deeper than you ever remember it once you're out in the real world. So like I just think of like in biomechanics when you guys were talking about Sphinx pose and like palpating the sacrum and the movement of the sacrum in Sphinx. I didn't remember that at all until you guys brought it up. This to pull. this guy, right? Yeah. Let me. Okay, cardiac output. What are the names of the slides that you guys have this week? So there's chapter 9, like this. Like this one is called the heart. Do you guys know what the other names are?
Cardiac arrhythmias and ECG interpretation.
One sec. ECG. This one. Does it look like kind of like this guy?
I'm pulling it up.
You said ECG interpretation, and then what was the other one?
Cardiac arrhythmias.
That might be a new one. I think he's still developing his material. So let me just quick look through this. The heart.
And I don't know if it's in that one or which one it's in. I'll have to pull it up and look at it. But the whole like drawing the vectors and all that crap.
I was
I
just
don't-
about to say that.
I
Oh,
don't
the mean,
understand
yeah.
it.
Axis.
MEAs. Oh my gosh.
Don't get me started.
I
have a
don't
one-on-one
get it.
today.
Ooh. Okay, we'll go into that next. Yes, let's go ahead and do that now before we jump into
Thank
EKG
you,
stuff.
Elizabeth. I was gonna bring that up, and I was like, we're on a
Mean
roll.
electrical access. Sweet. Okay. First question. I want everybody to answer this. Who here ever took physics?
I
I
took
did.
physics.
In high school, which has
Okay,
been
high
a long
school.
time because I'm old.
Joseph, Julio, did either of you take physics before?
Also
Nope.
took it in high school.
Okay, high school, Julio, you haven't. Okay, so make sure that I walk this step by step. So in physics, there's something called a vector. Okay. Has everybody heard this word before at some point?
Yep.
Yes.
Okay.
Yes.
Best thing to quote is from Despicable Me. The vector is a mathematical term represented by an arrow with both direction and magnitude. Oh yeah. I really hope somebody got that.
I got it. Totally.
So
I'm definitely sitting here chuckling. So
what mean electrical axis is telling us, essentially, what we're doing is we're charting when we do EKG stuff, right? So we have our little human right here. When we do EKG stuff and we put the electrodes on people, like the electrodes that we put on, do you guys already do the lab with the EKG?
yes.
Yep.
You know, you put
Yeah.
electrodes like on one hand and then another hand and then like on the ankle or whatever, right?
Yeah.
Yes.
So what the EKG does is it's kind of, so you put an electrode here to here, an electrode here to here, and an electrode here to here, and it sends a small electrical signal from electrode to electrode. And what it does is it picks up the electrical current that is running through your heart. And the reading that it gives us on the EKG to give us our little P wave, QRS complex, T wave stuff is it's telling us the magnitude, so how much electrical signal that there is, and also the direction that that electrical signal is traveling. Okay, because we looked at our heart, right? Here's our heart, our SA node. The electrical signal has to travel. Some signal has to travel over here, some to here, some this way, some this way, some this way, some way over this way, right? This, some of them is traveling this direction to get to all of the heart, right? And then it separates. And then all of this eventually comes and goes right here and comes together into the AV node, right? The electrical signal has to go out. So you can think of this when we're talking about the EKG, essentially what we're measuring is just tons and tons and tons of little vectors. We're measuring the direction and the magnitude of the electrical current as it goes through the muscle tissue. Have I lost anybody with this?
I'm
Not
picking
yet.
up what you're putting down.
Okay, you smelling what I'm stepping in?
For sure.
So the cool thing about vectors is that we can add them together. Okay, so it's kind of like this. Big up arrow plus baby down arrow gives us slightly smaller up arrow. It's like we're subtracting the directions of them. It's like up is positive, down is negative. Right? Or like left, big left, plus big same size right gives us 0 because they cancel each other out. Okay?
Mhm.
When we talk about physics, we got all up into like forces and pushing things this way, and then like the same amount of force being pushed back, all that kind of stuff. Similar kind of idea, except rather than a force or like pushing something, we're talking about electrical current. Our electric current is going to be representing like our force, like if we were in physics.
It's like physics 2, like ohms and
Yeah,
okay,
getting
stuff like
into
that.
getting into that kind of yuckiness. So what that means, so if we look at this actually, and even because it's not perfectly, you know, down and across, we can also have angled arrows. We can have an angle down and to the right and up and to the right or up and to the left or whatever like this. And we can still add these together, but we can treat them, so we can take this, you know, diagonal arrow and break it down. So this, I feel like I need to do something besides an arrow, equals a downward arrow and an arrow to the right. Kind of adding those, so that plus that. This arrow equals this. And so then if we add it to, we look at this arrow, that's going to the right and up. So if we add these together, down cancels up, right plus right equals bigger right. So we can add those together, okay? Does that make a little bit of sense? I know it's a little bit confusing to think of these arrows essentially as numbers, but
I'm with you so far.
okay, how's everybody else doing? I want you guys to talk to me.
Yeah, so far so good, I think.
Like a
I'm trying
little
to make
bit,
it
yeah.
make sense with what we've already been through.
Yeah, I
It's-
think just like making
Yeah.
that make sense with
Don't-
what
yeah,
he has talked
make-
about is like, huh?
Do focus on this first. We're doing baby
Okay.
steps.
Okay.
We're looking at the arrows first. The arrows have direction and they have magnitude. Okay.
Mm-hmm.
So up here in the heart, I'm going to draw a new heart because that one. So we have our heart right here. Just like this. Here's our SA node. When the electrical signal comes out, right, we have electricity going down and to the left. If you look at the heart itself, this is technically the right, so technically down and to the right, but whatever. We have it going down and to the left, down and to the right, down and to the left, right? If it's going to the right and going to the left, remember, right plus left cancel each other out. Overall, we're heading towards the AV node. So if we take all of these directions of electricity, the directions and the amount of electricity traveling all of these different directions, if we take them all up and combine them and kind of merge them into one, we get a general direction of directly from the SA node towards the left side to the heart in general. Does that make sense? Because we start at the SA node and we need to end up at the AV node. So in order to do that, we have to travel down and to the left.
Yes. Mm-hmm.
So when we measure that, we're measuring with these different, we call them leads. The leads have a, we have like a, just like any kind of electrical current, we have a positive end and a negative end. And that gives us, right here, see how this goes up, positive? That means overall the direction of the current is traveling in what is designated the positive direction. I know there's a lot here. We'll come full circle eventually with it, okay? And I'll show you kind of how to read mean electrical axis. So we're going from SA node to AV node, and then we go down the bundle, and then we come back up around with the Purkinje fibers. So this electrical signal that's traveling, that's going through all this, we're measuring that in these different leads, and it is turned into this signal right here. Let me go into actual mean electrical axis stuff. It's in here. Ooh, there it is. There it was. Where'd it go? I'm back. Here we go. Lots and lots of pictures here, but here we go. So here's the representation of our leads. It's from the right arm to the left leg, right arm to left arm to left leg. And there's a negative direction and a positive direction. So what we're going to do is we take all this information, like the positives, the negatives, all kind of stuff, and we try and simplify it into a neater circle. Because if you think about when you move, when you go anywhere, you can only really go, let's say if we're standing in one place, you can really only move one direction of 360 degrees. So that's kind of, we're going to make this flat. Actually, let me just pull up a piece of 3, 4, 6, 12. Excuse me. Okay. So what we do, we take a circle representing 360 degrees, and we assign direction of this circle. So let's start with going all the way to the right. We call this 0 degrees. We call all the way to the left 180 degrees. Down is 90 degrees. This is positive. And up is negative 90 degrees. Okay, 150. Okay. So what we do, we have this circle. I don't think the way that's sized. There, that's better. Let me do this. Easier on this. Okay. Move away. Circle. Looks so pretty. Good. This is 0 degrees. Up top is negative 90. Down below is positive 90. Off to the left is 180, or you can also call it negative 180, depending on which direction that you go. So what I want you guys to imagine is that we're placing the heart in this. So here's our heart. In general, the electrical wave from the SA node, AV node down the branches is in this direction. Okay? Does that seem fair?
Yes.
Yes.
So when we talk about a normal mean electrical axis, let's start with that. The normal mean electrical axis is somewhere between negative 30 degrees and positive 90 degrees. Because everybody's anatomy is slightly different, right? Everybody's heart, like my heart could be at this angle, it could be at this angle, it could be at this angle, it could be at this angle. Everybody's heart's going to be slightly different. Is that fair?
Yes.
And then also everybody's at a different point in their life where, you know, if they have some kind of heart condition, let's say like they have aortic regurgitation. Remember we talked about regurgitation where blood is flowing backwards, so it gets pushed into the aorta and then it flows back into the ventricle because the valve isn't working right. If we think about something like that, like let's say we're squeezing, let's say we need to push 300 milliliters of blood to the rest of the body in order to survive. if we squeeze and push out an amount of blood, and we need 300 milliliters to continue to do its thing, but let's say we have 200 milliliters that flow back again, how many milliliters of blood are we going to have to push through each time in order to get that 300 milliliters around to keep us alive?
500.
We have to push 500. Is it easier to push out 500 milliliters of stuff, or easier to push out 200 milliliters of stuff, or 300 milliliters of stuff?
300.
300. So if our heart is a muscle, if the muscle is working harder, what happens to muscle when we work them hard? When we work them out?
Hypertrophy.
Hypertrophy.
They get bigger. If there's a bigger muscle, do we think that muscle needs more or less electrical signal traveling through it?
More.
More. So let's say, for example, we have left-sided hypertrophy of the heart. So this left side is way bigger than it typically is. How is that going to change kind of our electric, or our flow, our arrow, the direction of the overall electricity?
More left.
Yeah, more.
Yeah, because it's going more that direction, so it's going to pull it more that way. So then we can see, we can get changes in the mean electrical axis, or the rough overall direction electricity is flowing through the heart. Is everybody more or less with me at this point? We feel okay about what I just said?
Yeah.
Yes.
Okay. So the mean electrical axis is going to tell us, it's going to help tell us, we're going to take the information that we get from the EKG, put it onto the mean electrical axis to help us look and think, okay, is this heart good? Is this normal? Is this what it's supposed to be? Or, hey, there's something funky going on here that we need to take a better look at. So let me pull up an EKG example. Did you guys have an EKG worksheet or something?
I can send you this one real
Electrical axis?
fast. I have it pulled up.
Yeah, go ahead and send that to me real quick.
Okay.
Is that the one from Lab, JC?
Yes. Mm-hmm.
Okay, I'm gonna pull mine up too.
Is it this one? Does it look like this?
Similar, but ours, I think it was in color.
Okay, send me that one.
Be
You're
thankful
sending
you're
it to.
mine's that one.
Yeah, that's the one that we used. This is the one that I had, and we had to do this one and zoom in, and except the way that she gave it to us, we couldn't zoom in.
That's tough.
JC, are you sending it in the chat here or
Group me. I can't get to the chat on this one.
me? Okay.
It's sent.
Okay. What the heck?
Did it send weird?
No, my group me just had a conniption.
Oh, okay.
I got it though. Okay. Bam. Okay. So what we do, we have a whole bunch of different leads. What these leads are is we focus on these 6 over here. Don't worry about these guys. We'll talk about those later. Leads 1, 2, and 3 AVR, AVL, and AVF. Each of these leads, like we mentioned earlier, has a specific direction that it's measuring. So I'm going to draw in here where each of these leads are. Draw. Boom. So we have, let me start with leads 1, 2, and 3. So we have lead 2. This is the positive direction. This is the negative direction. And that's at 60 degrees. At negative 30 degrees, we have AVL. AVL, this is, I'm not sure which way. I'll come back to
There
that. I
should
can't
be a
remember exactly
diagram
which is
on
which.
there too, Drake, if you want to use that too.
Is there?
Uh-huh. It's just below the first example.
Nice. Okay, cool. That saves me a lot of time. Let me just do this. Because I like working in PowerPoint best. Everybody has their ways that they do their own notes and stuff. I have personally found like PowerPoint offers a lot of, like, you have a lot of tools in PowerPoint. Okay. So we have this doesn't quite show all the details I want. So this is the positive direction. AVF, that's the negative direction. This is the positive direction. That's the negative direction. I'm pretty sure this is positive direction. That's negative direction. This is positive direction. That's negative direction. This is positive direction. That's negative. And then this is positive, negative. I'm pretty sure. Where's my? I tried to find my. I actually made one of these and I printed it out and laminated it.
We had a prettier one that he like printed out for us, but I don't have like a download or anything for it, a PDF.
Yeah, that's fine. It's fine. I just want to make sure that I get this set up right the first time, because to have to come back and re-explain this would be just an absolute pain in the butt. I want to make sure that I set it up right. Okay. Lead 1, negative to positive. Lead 3, negative to positive. Lead 2. So let's make sure. Lead 3, negative positive. Okay, that's all right. And then our, yeah, that's right. AVR is positive that way. AVL, AVF. Okay. We're set up right. Okay. So there's 2 ways to do this. There is the I really understand vectors and I have a great imagination kind of way. And then there's the holy frick, this sucks. I just need to dredge myself through this until I can get to the next unit. I'm going to show you both. So we look at each of these leads and we determine, okay, which ones are positive, which ones are negative, and how positive or how negative are they? Okay, and to do that, we typically just look at the QRS complex. Okay, so I like to start with the one that looks the most positive and like obviously like, oh yeah, that's positive. So lead one right here, very, very positive, right? Any argument there that the QRS complex goes very, very positive?
Nope.
Okay, I'm going to take silence as no disagreement. So lead one is going to be red. So lead one right here, it is very positive. So big arrow along lead one towards the positive side. Okay, there. Let's look at which one is next positive, or like which one looks the biggest. I would say, let's see if we can take AVR. AVR looks very negative. Clearly, the QRS goes negative. No arguments there. AVR. So we find our AVR line right here. Towards negative 150 would be positive. Towards positive 30 is the negative side. So it is negative. It's not quite as negative. So see how like this one goes up from here, half, almost like 2 full big blocks. And this one goes down maybe 1.5, so slightly less than lead one.
Excuse me,
It's going to
Drake.
be this direction here. What's up?
Why is the positive 30 the negative side?
Repeat that. What do you mean?
Didn't you just say that positive 30 is the negative?
No, I should say, yeah, the positive 30 direction is the negative value for the AVR lead.
Or AVR. Okay.
Yeah, specifically for AVR. Yeah, sorry. So AVR runs in this direction from negative 150 degrees to positive 30 degrees. So that's the direction, that's the way that it runs. And because it's an electrical lead has a positive end and a negative end based on like what it's like measuring. So like the up direction is positive, down direction is negative. So when we measure it, the negative direction of AVR is towards positive 30 degrees. A lot of positives and negatives in there, which get a little bit confusing. But if you see AVR is negative, that means our electrical signal is heading towards positive 30 degrees. Okay.
And I get how they labeled this now. Where it shows like the AVR label, that's the positive side. That makes a lot more sense now. Yeah.
Yeah. Okay. Next, we keep looking. Lead 2, overall, it's positive, but still, but a little, kind of small, right? So we look, lead 2, still positive, so it's going to be this direction, but it's a little smaller, right? AVF, and there's a reason why I'm skipping leads 3 and AVL. We'll come back to those in a sec. AVF overall, positive, but very, very small, even smaller than lead 2. AVF is here down. AVF. So at this point, we can look at these, right? And say, okay, overall, if we were to add all these arrows up together, right? Overall, it looks like our direction is going to be somewhere kind of this-ish direction. Does everybody see how I kind of got that assumption?
Yes.
Yes.
Because all of these arrows, if we were to do like the breakdown of like all of the arrows and like do like that little, oh, this big arrow is this direction and this arrow is this direction and add them all up, our overall direction is going to be towards here, a little bit closer to positive 30, between positive 30 and 0, because, these are a lot smaller and these are much bigger. So the best guess is we're probably within this range between 0 and 30 degrees. So yeah, when you have a multiple choice, you're not going to be able to tell like, oh, that's going to be like 23.6 degrees. That's not the way these questions work. You're going to get a chunk, like an in-between range of 30 degrees. So like when this would be a multiple choice test, answer choices that he would give you would be like negative 54, positive 120, positive 98, or 25 degrees, positive 25. And of all of those choices, positive 25 fits within our range. How I got to this point, does that roughly make sense?
A lot more sense than it did.
Not really, but go ahead.
Not really. Okay. I'm going to show you the other way to get there. It takes a little bit more time, but kind of helps you start to figure out to get to this point, okay? Let's do this same one in the little bit of the longer way that'll still get us to the same answer. So the next way that we can do is called the shading method. So the way that this works is we're going to use the lines that are perpendicular to the leads. Okay, so for example, lead 1. This is our lead 1 line. Okay, we have above and we have below lead 1. So this is our lead 1, and we can see to the right is positive. So we're going to say we look at the perpendicular line. This is the line that's perpendicular to our lead 1. We say everything to the right is positive. Everything towards the negative side is negative. Okay? Are you following with me so far?
Yes.
Okay. So we look at lead 1. Overall, is lead 1 positive or negative?
Positive.
Positive, because it's going up. Up is positive, down is negative. So up is positive, down is negative. So it's going more up. The QRS complex is going up. So it's more positive. So we know the direction has to be towards the positive. So we're going to shade all of the negative and say, okay, none of this can be black. None of this can be the mean electrical axis. Okay. Now we move on to the next one. So like AVR, right? AVR, we find our AVR. We're right here. So this line right here is our AVR. We look, okay, what's the line that's perpendicular to AVR? It's this line right here. 120 to negative 160 right there. So we look at our AVR. Okay, towards this direction, this is positive. Let me get rid of some of this so it's a little bit easier to see. Oops. This was all shaded in. So we have our AVR line here. We have the line that's perpendicular. This side, this direction, is going to be positive. Okay, so this side of the line is going to be negative because that's the positive direction. This is the negative direction. Still with me?
I think.
So it's switched for the AVR.
Yeah, because we need to look at that. That's why setting it up, drawing this setup is super important so that you know which lead is on which line and which direction of the lead is positive and which direction is the negative. And actually, let me do this. This might help a little bit. Let me do this.
About to have to go. This coffee shop's about to close. So,
You're good.
will this be recorded?
Yeah, it's the whole thing's recorded, and I'll post it to
Awesome.
YouTube as soon as we're done here. So,
Great. Thank you, man. Appreciate you.
of course, take it easy. Lead 1. Specific lead 1. Positive. AVF. Positive. Negative. It's going to take me a second to set up, but I think this will be a little nicer to start out with. AVL. Positive. Here. AVL. Negative. One negative. Two positive. Two negative. One, two, okay. One, three. Okay. Elizabeth, is that a little bit easier for your brain to look at?
I think so. I don't know. I don't know what isn't clicking. It's just not.
This is one of those things. I mentioned this before. EKGs are one of the things that you honestly just kind of have to do enough of them to make it click.
I
So
think
we're
the
gonna.
two things where I'm confused is, one, how do you know where on the wheel that they go? First of all,
The direction of things.
yeah, like how do you know
this
that
is
like
always
one is
where
always on 0? Like how do you?
Because
It
that's
just
just-
always is, or
Yeah.
Okay,
That's just the way it is.
okay,
You
that
can
makes
tell
more
it's
sense
that
because
way
I'm like,
because of the way it is.
is every
Yeah.
wheel different, or is
Yeah,
it
no,
always
no.
there?
It's always going to be this wheel.
Okay,
it's
so that makes
always
sense.
going to be exactly like this. Okay.
Okay,
Okay, that's
got
one
it.
thing. Well, you said there was a second thing?
The other thing is, like, when I'm looking at it, so is the AVR not on lead 1? Like, why is that different?
So essentially what we did was we took a person, right? So we have our little stick person, right? And we hook them up with leads. So for example, lead 1 was from this hand from the right wrist to the left wrist, right? And so we're measuring negative, positive. We're measuring from here to here, like that. Okay? Does that make
Okay.
sense?
Yeah.
This is lead 1. We remove those leads, take that same person, and now we put an electrode here and an electrode down on the ankle. And we measure negative, positive, like that. That's our lead 2.
Okay.
Okay, so then if we look at our circle, right, straight across is lead 1. That down to the angle is lead 2.
Okay.
Then we take that person, hook them up, electrode here, electrode there, bam, measure here, negative, positive. That's lead 3.
Okay.
And then the same thing with AVR, AVF. I don't know the exact placement of AVR, AVF, but same thing, the direction of it. So like AVF is going to be, actually let me do this. Lead placement for AVF. So AVF is going to be measured from ankle just straight up. So see AVF straight up and down. AVL from the center lead. I think that they put I don't know, I think that they like put a lead. Yeah, I remember that you put a lead like on your, like towards your, like near your belly button when you're
Okay.
measuring AVF, AVL, and AVR. And so you're measuring from that point right there on your belly towards the one on the left wrist for AVL. So AVL right here, here's our belly button. There's the positive direction. So the opposite is our negative direction. AVF, we're measuring from the lead on the ankle up towards, or we're measuring from the belly button down towards the foot. The belly button right there, down towards the foot.
Mm-hmm.
So essentially what we do, we take each of these leads, these directions of leads, we take all of them, and essentially what we do is we take our lead 1 and we overlap it with our lead 2, and then take that and overlap it with the lead 3. So we get all these different directions. But so really what we do is we take this guy and say, okay, this is our across like that. And then we take this guy, and now there's that angle. And then we take this guy. Okay, there's that angle. And when you put them all on top of each other, you end up with leads going in each direction every 30 degrees. And it looks like a circle.
So on the readout, why is like 1 and ABR on the same, like, I think that's where I'm getting confused, is because is it just like break it up into chunks, like the readout, or I don't get it.
What do you mean? What do you mean by the
like
readout?
on the chart with your QRS complexes and stuff, like everything that you're looking at to decide if it's negative or positive. So like your lead 1, it has the lead 1 there, and then there's like 4 beats, like 4 complexes, and then it says ABR. So is that just like, so that's your new Like, that's where I don't understand.
Okay, that's just how it's broken up. So the way that an EKG like prints is, let me show you. So think of it more like this. Oh, I want you to open in the other thing. I get where you're confused. Oh, I could have just done this. Let me do this. Instead of thinking it like this, think of it more like this. It prints and it looks continuous, but they're completely separate. So this is our lead 1, our lead 2, our lead 3, and it ends right there when you hit the AVR. Now this is a completely different lead. This is the AVR lead and has nothing to do with lead 1. And this is the AVL lead and it has nothing to do with lead 2. It's this completely separate thing. When it prints to save, essentially to save paper and space, they like stick them right next to each other, but they're completely separate. They're their own things.
Okay, yeah, that's where I was confused. I was like, that's all in the same, like, I don't get it. Okay, that makes sense.
Yeah, if you look
It's just
really
chunks
closely,
instead of
if you look really closely, see the tiny little break right there?
yeah.
Yeah. It's just the
Okay.
way it's printed. Okay. Does that make a little bit more sense though?
Yes.
Good. Okay. So let's look here. Keep this separate. Bam. Just looking at lead 1. Just looking at lead 1. Is lead 1 positive or negative, Elizabeth?
Positive.
Positive. So what we do is we come to our little drawing and we find lead 1. Lead 1 is right here. Okay. So we find the line that is perpendicular to lead 1. Right here. Anything on the positive side of that perpendicular line, so anything up, this is all positive, this is all negative. So we note, okay, lead 1 is positive, so our correct answer is somewhere here in the positive. So we can get rid of, cross out all of this negative stuff. So we know that the lead, that the mean electrical axis is not in this direction. It's somewhere in this direction. And then we move on to the next one. So lead 2. Let's look at lead 2. Lead 2 is right here. We find the perpendicular line to lead 2, which is this line right here. Then we look, okay, sweet. This is positive, because that's towards the positive side. This is negative. Is lead 2, the QRS complex, are those overall positive or negative?
Positive.
Positive again. So then we can look here. Okay, so all of this above here negative. We already have all of this shaded out. We can additionally shade out these 2 boxes, or these 2 triangles, these slices. That narrows us in even a little bit more. So then we can look and say, okay, what do we have left? Lead 2 we already did. AVR. Lead 2 we already did. Lead 1 we already did. AVR. Let's take a look at AVR and see what's up with AVR. Because AVR is going to help us the most next. So is AVR, hold up. You should be negative. You should be positive. Okay. Good. Is AVR overall negative or positive?
Negative.
Negative. So first step, we're looking at AVR. So what do?
Perpendicular line.
Yeah.
To
We find
AVR.
our line, and then we find whichever's perpendicular to it. So we look, bump. This guy right here is perpendicular. So then we identify, okay, from this perpendicular line, everything to the left over here is going to be positive. Everything here to the right is negative. And if we look at this, it doesn't really help us much because we already have positive. All that's already shaded out. Negative, don't have much here. So then we move on to the next thing. Let's look at.
Okay. Drake.
Yep.
So I know that AVR was positive, but how did it turn into being negative on the right side if it was positive? That's what
I messed up when I drew this chart. It was supposed to be negative. It changed it. I messed up when I was filling it out.
So on the right side, or if you look at it that side, the left side, it would be negative, and then on the right side would be positive.
For AVR,
Yes.
towards the right side down here, this is negative on that right side. I messed up in the beginning and I accidentally had a positive here.
Yeah.
When it was supposed to be negative.
Okay.
That was my mistake. So I corrected that, changed that to a negative. And if we look at the overall, so we look at the little line that's perpendicular. When we're looking at AVR, everything here heading in this direction towards the left would be positive. Everything heading down towards the right would be negative. And we look at our AVR on the EKG, and because it's mostly negative going down, that's the side we want to keep. So we would shade out all of the positive side over on this side, leaving us here. And previously we had done lead 1, which also got us that slice out as well. So we know that our answer is somewhere. Now we're narrowed down to somewhere in this specific range. Okay.
Okay, got it.
Yeah. My bad. I messed up when I accidentally put that name. That's why, like I said, I try to double check as much as I can. So then we can keep moving along. AVF, positive. So AVF, let's look at AVF. First things first, we identify which line is AVF. It's right here. Then we find the line that's perpendicular to it. Okay, this side is positive. That side's negative. AVF is positive. So we can shade out anything that's negative. That narrows it down even more. Now these last two, let's actually look at lead 3. So lead 3, when we look at this, and if I ask the question, is that positive or negative? How would you respond?
More negative.
Slightly more negative, but it's got this honking positive on the other side. That's that's pretty similar, right?
Like isoelectric.
Yeah. So what the terminology that we use to describe this, let me actually pull up this guy. We call it biphasic. Okay? Biphasic. So we have it's either obviously negative, it's obviously positive. Or if you have them like this, where it's like, you know, almost even on both sides, or maybe it's a little bit more positive, but then has a nice negative dip, or it's a little positive, but then a bigger negative dip, we call these biphasic. Okay? When doing our line test, and if we're just drawing vectors, if we have, the goal is to not use these if we don't have to, because they're a little bit trickier to use.
I think that's where Dr. Tate confused me, because he wanted us to use, I guess that would be the isoelectric line then. And he's like, use that. And I'm like, I don't understand. What?
Depends. So let's look at this, lead 3. So essentially, biphasic, the information that it gives us, you need to use it together with the rest of the information from one that's either really positive or really negative to figure out what it's saying. Okay? And I'll explain how. So biphasic, what that means is that it's not going towards the positive or going towards the negative. If it's like this is pretty close to same size negative and positive. So that means our vector, the direction of electricity, is actually going perpendicular to this lead. So we look at lead 3 right here. Here's lead 3. We check it. We look, we find a line that's perpendicular. This is the line that's perpendicular right here. We have our lead 3, we have our positive side down here and our negative side down here. And we look at this and we say, well, oh, wait, no. I'm remembering. I wish I could just. Lead 3 here, negative side, positive side like that, right? Negative side, positive side. So what we do, we look at our lead 3, and what this is telling us, because it is biphasic, right? Like this, what that means is that the signal is traveling perpendicular to this lead. So what this tells us is that lead 3 could be what the heck is my brain doing? Hold up. 3, boom, negative side, positive side, all through there. Not so important. Okay. So along lead 3, we know that because it's perfectly biphasic, the direction is either going perpendicular one way or perpendicular the other way. Okay? Because it's biphasic, perfectly biphasic means that it's going exactly perpendicular to that line. If, for example, let's look at AVL. AVL has big positive, some negative, right? I should leave this whole thing because I need to. AVL, we identify where AVL is. Right there. We identify the line that's perpendicular. We say with AVL, this is our negative side. This is our positive side. It is biphasic. So we would think, okay, it's perpendicular to it. But because it's more positive than it is negative, we'd say it leans more towards positive. So it's actually this direction or this direction. This is where, like I said, you just kind of have to do enough of these to kind of start picking up the pattern of what's going on. And if we looked at the whole thing previously, we had highlighted out all of this, right? All of this was gone. So now we have two biphasics telling us it's either this direction or it's this direction. Cut the difference in between the two, somewhere between 0 and 30 degrees. And that's going to be where our answer lies. I know we're probably still confused. Let's just jump in and do another one to start to look and see the patterns. Okay. So we look at our 6 different leads that we can use. Which ones are obviously positive or obviously negative?
2 and 3 for sure.
2, 3, and also AVF down here too, right?
Yeah.
Okay, so let's start with lead 2, obviously positive. We identify lead 2. We find its perpendicular line. We look to see, okay, this is negative, this is positive. Lead 2 is positive. So we shade out all of the negative space. We're not going to mess with any of that. Continuing on, lead 3. We find lead 3 right there. We identify the perpendicular line. We look at this, okay, perpendicular line. This side is negative. This side is positive. Lead 3 is positive. Shade out the negative. Next one, AVF. AVF is very, very positive, so we identify AVF. Identify the line perpendicular. That's negative. This is positive. AVF is positive. All the negatives already shaded out. We move on to the next one. AVR. Identify AVR. Identify the line that runs perpendicular to it. AVR, we look at the side. This side is positive. This side is negative. AVR, is that negative or positive?
Negative.
AVR is negative. So we're going to shade out this piece right here. AVL, is the QRS complex negative or positive on AVL?
Negative.
Negative.
So we identify AVL, find the line that's perpendicular. This side is positive, this side is negative. AVL is negative. So we shade out the positive.
Hey Drake, can you send that template that you're using for shading into either the chat or because I actually wish I would have had that last week doing my damn assignment.
Yeah.
Yeah, I might have been
So
able to actually do it.
Here's the thing, I got a
finally,
50
here
out
we
of
are.
50 and I screwed it up.
Yeah. So right now we did 2, 3, AVF, AVL, AVR, and AV1. If we look at AV1, so it looks very nicely biphasic. Don't try and like super read into it. If it looks pretty similar, like you can make an argument, oh, like this one's a little bit more negative, oh, this one's a little bit more positive. You could make that argument. They look pretty dang similar, pretty close. Just call it perfectly biphasic. If it's perfectly biphasic, that means our vectors are perpendicular to the lead. So, and it can't be this direction because that's all shaded out. So we know our answer is going to be somewhere in here. So somewhere between 60, 90, and 120. But somewhere between 60 and 120 should be our answer. And that's as close as we can get it. So more than likely, like the answer choice on a multiple choice test is going to be like 90 degrees, 95 degrees, 86 degrees, something that kind of reflects that it's in the center here somewhere. Did that make sense? How kind of what that process was to do that?
Yes, that makes so much more
So much
sense.
more sense.
Good. Now,
It's a little
as
more
we-
time consuming, but who cares?
it is more time consuming. The trick is do it over and over and over and over and over again. And after you do, you know, like however many has here, after you do 8, 9, 10, however many of them that you have to do, it gets easier and you get quicker at it. And then you can start to pick up patterns. And you can also, like, for example, you can look at your answer choices. So if my answer choices were, the question was, and the answer choices were 86, negative 30, negative 90, 92, and then 145, right? Okay, we look at our answer choices. Let's look at this. Okay, lead 1, biphasic. We're either biphasic. We're either here or here because that's perfectly biphasic. Immediately, it's no way it's negative 130. No way it's negative. It's positive 145. Lead 2 is positive. That's this direction. That gets rid of that. Answer is 86. I did that really quick, but you see how I mathed my way there?
Yes.
I say do all of them at the beginning because it helps you learn, and it takes more time consuming and it sucks, but it helps you get there. And once you can get there consistently, that's good. Also, Elizabeth, when you see something like this is just an extra printout of stuff. So ignore all of these, ignore all of these down here. Just focus. Lead 1 ends there. Lead 2, lead 3, AVR, AVL, AVF. So we look at this one, and again, I like to start with if there's a really perfectly nice biphasic one, or if there's a really positive, really, really negative, one of those are the ones I like to start with. So we look at these, and Kristen, which of these would you like to start with? What's either really, really positive or really, really negative? Kristen might have stepped away.
Oh, there we go.
Oh.
Sorry.
Which
I thought
you wanna
I was
start with?
unmuted, but I wasn't. Let's do 3. It's really, really
Lead 3.
negative.
We identify lead 3. And I'm not gonna do the identifying line. So we have lead 3 right there. Here's our perpendicular line. We look to see, bam, bam, bam. Perpendicular, this direction is negative, this is positive. Lead 3 is negative, so we get rid of all the positive. That's all gone.
Yep.
Okay, JC, which one do you want to do next?
Let's go with lead 2.
Lead 2. Here's our lead 2 line right there. We find the line that's perpendicular to it. This side is positive, this side is negative. Is lead 2 positive or negative?
Negative.
Negative, bam. Get rid of all the positive. Julio, which one do you want to do next?
AVF.
Is AVF positive or is AVF negative?
Negative.
Good. AVF is negative, so here's our perpendicular line. AVF, that's positive. This is negative. So we look here, all of our positives already shaded out. So perfect. So we just keep on rolling along. Elizabeth, which one do you want to do next?
AVL.
AVL. So here's our AVL. We find the line that's perpendicular to it right there. Is AVL positive or is AVL negative? So this is the positive side, that's the negative side.
Positive.
Positive, so we get rid of the negative. At this point, typically you can look at your answer choices and tell if there's an answer choice within that region, bam, you're good to go. If not, then you have to keep going. So let's look at AVR. So AVR is right here, line is perpendicular to AVR, right there. Is AVR positive or negative?
Positive.
Positive. So AVR here, perpendicular. This is the positive, this is the negative. So shade out the negative.
Last one's lead one.
Closer. And lastly, lead one. Lead one, like basically
Positive.
neutral, a tiny bit positive, probably like, because this is so small, like biphasic-y, but more positive. So like if we look at this, okay, so we know it's towards the positive side, so it's more likely going to be within this range than it is within that range.
Negative 85-ish.
Yeah, somewhere in there, somewhere between negative 60 and negative 90. And that's good enough to give us our answer.
I cannot explain how much that just helped. Like, light bulb went off, it's working, pistols are firing, we're winning the game.
Good.
Exactly. And explaining isoelectric as being biphasic made sense in my athletic trainer brain because you know modalities.
Yep.
Like,
Same here.
Good. So now let's take a step back really quick so we understand what the heck, like how to do this. Now let's really quickly talk about what the hell does this mean? Okay,
Could we use that as an
why are we
example?
doing this?
Quick question. Can we use this
Yeah.
example and just kind of go through that first problem that we got on our homework this week so we can understand it from this perspective because it's weird?
Which one?
Did anybody give them the homework we got this week yet?
I can get it real fast if you need me to.
Yeah, please.
I haven't even
So
looked at
one of
that.
the
Didn't
first-
even know we had anything. Cool.
Yeah, our lab for
Same, but
phys-
I'm looking at it.
Our lab for phys this week is not our typical lab like we get with McGraw-Hill, like for blended. It's retarded, but it makes sense because I've done case studies like that before.
What's the document name of it?
Let me look. I got mine open in.
Is it one of like the lecture activities or is it?
It's actually a lab activity this week for blended. You guys might have something similar in traditional. I don't know. The document is called Week 6 EKG Case Studies.
Yeah, I don't have that.
How about I send it real quick? I have them both downloaded.
Might be a blended thing, but yeah, we can take a look at it.
All right, let me send it.
While you're sending that.
Do you want me to send an email or in the chat?
Either way, whichever is
I'll put
easier.
in the chat.
I also went to week 6 and I found the thing that I was looking for, the circle. I found the one that he sent us that was very pretty.
Okay. I'll also just
Give me 1 second. Where's my stuff for this week? It's in my downloads, I believe. Oh, fudge, where'd it go?
I'm also gonna go ahead and post a picture of this one in the chat if you guys want to use this. I recommend, like I said, I printed one out and I laminated it so that it looked really, really pretty.
I just sent you the one that we had too. It's very nice.
Giving
I'm
me
liking this
1
one
second.
that you just put in the chat because it gives me negatives and positives on both sides. I like that.
Yeah. But also, yeah. I personally like the, this is the one that he sent. I like when it's a pretty circle and not just lines. And I
Same.
think the degrees can throw you off a little bit. Only thing that I'd probably add onto this one would be like, I'd probably add in like 0, 90, 180, and 90. Like that's all the numbers I'd probably add, and just make sure you count properly.
I just saved
when you're
it. Where
doing
did
your
it
stuff.
go? What the crap? This way.
Okay, where am I? Okay, so like we mentioned before, our normal mean electrical axis is between -30 and +90 degrees. Okay, this is our normal. There are only 3 things that we talk about that can cause our mean electrical axis to deviate from normal. One is called a bundle branch block, sometimes seen as triple B. Not to be confused with triple D, diners, drive-ins, and dives. I missed that show.
So do I.
Okay, so bundle branch block is one. If we remember, think back to when we talked about the pathway of the heart, how after the bundle of his, it splits into 2 bundle branches. You remember that?
Yes.
Yeah.
So what can happen is one of those bundle branches, for whatever reason, essentially like stops transmitting the signal. So for example, we have our heart right here. We have our SA node. We have our AV node, bundle of his, and then the bundle branches right here. For some reason, one of these bites the dust. So what happens is this bundle branch, the opposite monomer, so in this case, this is the right side. The right side gives out. So now the left has to send a bunch of signal all the way this way. So because it has to send signal now sideways, that changes the direction of the electricity. So the bundle branch block, if it is a, let's even let's break it down. So if it is a right bundle branch block, we get deviation to the right. Let me double check this real quick, because I'm not 100% confident on this, and I do not want to tell you guys wrong. And this is technically getting into like the next chunk of stuff. So I don't think physiology
We talked about those in our lab too. So
yeah, the abnormalities. This starts to get into like, this is kind of what should be week 6-ish stuff. Enable. Control F.
yeah, it's left to the
Bundle.
left bundle branch and right to the right bundle branch.
Okay. Okay, could you repeat that? Right to the
So
right bundle branch blocks deviates to the right.
yep. Right axis deviation. Mhm.
Left frontal branch block, left deviation. Two of them go to the same side, and then the other goes to the opposite side. Other option is going to be ventricular hypertrophy, like we talked about that example where if the muscle gets way bigger on one side, it's going to pull more current. And then the other one is
Current of injury.
yeah, injury. So you can have something like an MI, myocardial infarction, where you have tissue death like an MI. And because if tissue is dead, it's not getting signal at all, right? So that means, so like let's say if we have left ventricle MI, right deviation, right ventricle MI, left deviation, because the dead tissue isn't going to work. So left hypertrophy, left deviation, right hypertrophy, right deviation. Left hypertrophy is way more common than right hypertrophy.
Is that just because like atherosclerosis in the arteries and stuff, or?
Yeah, well, it's also because within the lungs are never have the same amount, like never have crazy amounts of pressure unless like there's serious issues going on.
Okay. Could left hypertrophy cause right hypertrophy?
Eventually, yeah.
If it's enough pressure built up, I guess.
Yeah, over time. I remember this. Hold up, I might still have this. Let me see.
And the heart rhythms are on the
Oh.
second, I believe.
Yeah, y'all's lab looks a little different than ours because ours was kind of the same, but a little different.
I figured he's not gonna make them. He might make them the same between the two. Who knows?
Mm-hmm.
Either that or all your cardiac rhythms are on one page with it.
Well, I think they're a little different because we had to use our rhythms that we used on the actual like biopack machine.
Yeah.
Lucky. Actually,
I
like
hated the
machines.
biopack stuff. It was annoying.
It is annoying. I still haven't even finished this lab because he didn't give us enough time.
Yeah, he lectured for like an hour and 15 minutes, and we had 35 minutes to get it done.
Hey, Kristen, you have my notes, don't you?
I do, yeah. Crap, why didn't I look?
It's all in there.
Woohoo!
Yeah. All right. Well, let's
That
look at
makes
this
sense.
though. A case history. So patient. Oh, this is getting into like a little bit of the next stuff with like the blocks and such. Which it's already 10:30 my time. I think we're gonna have to call it a night.
Yeah.
For tonight. But we got through a lot, which is good. We can plan on knocking through this a little bit later with EKG stuff. Go, if you have my notes, go through them and look at this stuff, because you should have Dr. Van Winkle's PowerPoints, as well as, let me find, is it here? Taking forever to load. Here's the one that I would use. I'd use one like this and then drew the extra lines on it. Not that. Where is it?
Which folder is that in your notes, Drake?
Exam 2. Here you go. This is exam 2 lecture material.
Okay.
So this gets into the next chunk of stuff a little bit. So like this has all of those definitions and stuff, like the specifics that you want to know, as well as when you get into, when we start looking at it, like the more EKG stuff, looking at like the abnormal stuff.
Which is stuff I'm actually good at, which is kind of funny because I
Yeah,
can't
all
do
the
basic
all
crap.
the abnormal stuff. So like this is where I personally recommend, for understanding EKGs themselves, Ninja Nerd has a fantastic video on EKGs. That's what I see. Ninja Nerd EKG basics. This one right here. It's lengthy, but he does a phenomenal job walking you through every single little component of the EKG. Like you can see, he does like, and he'll go through and he'll draw. So like the very first part, like that's the P wave, and he goes through and he kind of starts a little later. The intro, isoelectric line, it's in like here. So he'll draw and he'll show you like, okay, we're at the SA node, and like this is what's happening with the electrical signal. It's going through here at the P wave. This is everything that's happening. So then we have all of that happening right there. And then we have that PR segment versus PR interval and what's happening during each of those. Then from there, the Q, kind of what's happening at the Q wave, kind of that traveling part. And then it keeps going the exactly what the Q wave is, and then the R segment, exactly what's happening and why it's so big, and all that. So he walks you through every single one of those parts, and it was super good. And if you can like organize in your head, sorry, I'm just like mindlessly scrolling through this, but if you can organize in your head, breaking it down and writing it out to like mini definitions, literally like, hey, the P wave is this. The P wave is atrial depolarization. Where does that fit into the whole process? Okay, that's when electrical signal is traveling from the SA node to the AV node. Okay, so what kind of issues or things could you experience with that? Okay, if the P wave is like too small or looks kind of janky, what could be going on? Okay, if the P wave is too small, that means that there's not as much signal as there's supposed to be. If there's not as much signal as supposed to be, think stuff like, oh, there's tissue damage, tissue injury, or like something isn't innervated properly, or there's muscle loss, anything like that. Or what if it's too big? If it's way too big, okay, you start thinking stuff like potential hypertrophy. Why could hypertrophy be caused in the atria? Okay, it could be like a backup of something. So things like regurgitation, any kind of hypertrophy. If there's a regurgitation of those AV valves, then you know the atria is going to be having to work harder So like you start to connect the dots, connect the pieces. So then you can also say, you can reverse it. Okay, let's say you have mitral valve regurgitation. What would you expect to see on the EKG? Okay, so mitral valve regurgitation, it goes back into the left atria. If it's stuck in the left atria, there's more blood there. It has to work harder to push it all out. Working harder gives you hypertrophy, so you'd have a bigger P wave. Do you see how I kind of worked it forward and then worked it backwards?
Yes.
Mm-hmm.
That's the kind of thinking and thought process that this course starts to push you towards, is being able to go and kind of think, okay, what causes what, and be able to kind of reverse engineer that as well. So again, highly recommend this video. You probably only need to watch the first half hour of it to really understand like each of the individual components of the EKG. That really, really helped me. But then you notice and you can start to look and see what things look like AV block. What is AV block? Okay, so it's where the signal can't get through the AV node. If that happens, what are we going to have issues with? Okay, so if the signal is blocked, there's a couple different types. If it's held longer than it's supposed to be, where do we see like the AV node in the EKG? Okay, that's during, because we have atrial depolarization is the P wave, and then the purpose of the AV node and the AV bundle and bundle of his is to pause. Where do we see a pause in the EKG? Oh, the PR segment. Okay, so what's the normal PR segment time? Okay, that's that 0.12 to 0.18. In like, I think it's 0.12 to 0.2, I think is a normal PR. Oh, it's PR interval. As PR interval is normally like anywhere from 0.12 to 0.12, I think it's 0.2, depending on whatever numbers he gives you. Okay, so if it's longer than that, that's because that PR segment is longer. So there must be an issue within the AV node or the bundle of his that's causing the signal not to get through. And you just keep working through it like that and talking through it like that. Okay, I think I've talked enough. Hopefully, you know, all of that kind of gets rolling, starts to make a little bit more sense. If I were you guys with mean electrical axis, go back and redo that mean electrical axis assignment, knowing now what you know, and work through it. And practice it, compare it to what you did beforehand, and see if you can catch mistakes, what you missed, what you got right the previous time, and to be able to cement in your mind the correct way to do those things and just get the reps in.
One more question, Drake. Point me to the folder if you can for the one that we have this week, because I can't find it. I'm scrolling through it and I'm like, which one is it?
School. Yes, love. I know, I'm coming. This one, try 2 year physiology. So we're here. Exam, it should be lab exam 1 material.
Okay.
Lab manual study. You know, I might have removed the completed version to, yeah, I bet you I did. No, it's right there. Week 5.
Okay. Thank you, because I didn't know,
Yeah.
because we don't have the lab manual technically for our class.
Yeah, well, you have it, so.
All right. Thank you, Drake. Go enjoy your evening, and thank you guys.
Yeah.
Thank you guys for pushing through. I know this was a lot, but we made really good ground. So hopefully this sets you guys up, to crush the rest of this week.
That helped immensely. Thank you so much.
Now I just gotta pass clinical imaging tomorrow.
If you're having trouble with clinical imaging, Rick Murphy, reach out to Rick Murphy.
Okay,
He's does all the clinical imaging. He's super cool.
awesome. Thank you guys.
Thank you.
Thank you.
Kristen or Elizabeth, are you guys able to see the chat?
Yes, now I am. I had to get into the tutoring team, but now I can see it.
Okay. Could you do me a favor and just download all the stuff that I put in there
Yep.
and send that to whoever needs it?
I sure will.
Thank you so much. I'm gonna try and get this downloaded and uploaded to YouTube tonight. Yeah. Okay.
And
Have a good night,
then
guys.
I'm
Take care.
going to, I'll text you tomorrow probably. If you still will help me kind of go through my routine and figure out like where the disconnect in how I'm doing and what I'm putting in is.
Yeah. Just shoot me a text. I have the day off tomorrow from clinic duties, so I'm just gonna be grinding through. Got a couple papers to write and working on my thesis, so I'll be around pretty much all day.
Okay, yeah, I'll shoot you a text sometime tomorrow and see if we can set up something. So
Sounds good.
thank you, sir.
All right. Good night, everybody.
Good night.
Thanks, Drake.